have on our list. And yes, of course, feel free to ask questions along the way. We'll also be sending a link to that recording as well as the slide deck from this meeting. So without further ado, Emma and Hope, are you on the call?
Yes, yeah. Can everybody hear me okay?
Indeed.
Brilliant. Okay, I know in the last couple of webinars we've spoken about the Bowel Grid tool as one of the tools people can use to support them in addressing inequalities in bowel cancer screening. And you may well have heard these slides before, but for anybody who's not, I thought I'd give a quick recap of what the tool is and how it can support people. I have just popped a link to the tool in the chat as well, if you want to explore it. I've just seen in the chat, can hear but can't see anything. Blank screen, so I don't think people can see anything at the moment.
Oh, could you perhaps take control? Do you have that option, Emma?
I don't know. It says it's blocked by the administrator. Sorry.
Okay, just bear with me. Okay, I'm just going to launch the slides again. Hopefully you can see those.
There we go.
Can we see the slides now?
I can see them at my end. Oh, got a few thumbs up. Brill. Looks like we can see them. I'm not able to take control though, so I might just say in Chris Whitty style, next slide. Next slide, please.
Sure.
Thanks, Walter. Yeah, so next slide, please. Sorry.
Yes, I think there might be a delay. Let's try that again.
A few people saying they had to leave and rejoin.
Okay, let's drop that and try that again. Excuse me, everyone. Can you see that? You might be on mute there, Emma.
Oh, sorry, just saying I can see it on this end, and I think we've got a few thumbs up. I think we're nearly there. Sorry, technical issues. And if you just click again, Walter, it should bring on some circles. Brill, thank you. Yeah, so just to recap what the Bowel Grid tool does. So essentially, we've looked at research UK-wide, research and evidence and data UK-wide for the groups of people with lower uptake of bowel cancer screening. And then the barriers that those groups have reported and enablers to participation. And then using behaviour change modelling, we've mapped interventions to those barriers or enablers that should be designed to address them or capitalise on them. And then crucially, Hope in our team has looked at the published evidence around those interventions, the impact of those interventions on inequalities, so improvement of uptake for those specific groups. Now we know that the groups, there's intersectionality between the groups, and there may be other groups that are missing from the data. For example, sort of missing patients who are not registered with a GP, perhaps don't have a fixed address. And so it might not show that there's lower uptake, but this is based on the data that's available. And we strongly encourage folk to use it alongside sort of local data and insights as a tool to sort of recognise which interventions might be most effective at addressing inequalities, both within and across groups. So you're able to look at interventions across groups, you can select multiple groups in the tool, or you can select an intervention and see which groups it's most effective against. So a starting point really to guide you on which interventions according to the evidence might be most impactful and a sort of map to those specific barriers those groups face. Next slide, please. And this is just a screenshot of the tool, but I did drop the link in the chat. I can always drop that in again for anybody else who's joined actually. But it's an Excel-based tool, so hopefully familiar platform to most. Not another dashboard is what we've got at the moment, but it's something that we're looking at maybe translating to online in the future. But you can see on the left-hand side there, there's the first column for the groups with lower uptake, and then the next one along is the interventions that have been mapped to the barriers that group experience, and then in the middle, the pink columns is the improvement in uptake, both at the group level and then at the research population level. And we've kind of categorized that with hopefully easy to interpret colors for sort of very high impact down to the lower impact. But it's worth noting that even those lower impact interventions are worth sort of exploring and considering, because although they might be lower in terms of the percentage improvement, the group might be a larger group, for instance, men who make up a large proportion of the population. So a lower impact intervention may still have a sort of significant improvement in uptake for that group. Next slide, please. And then there's just a bit of an overview. I've probably already spoken to these points about how the Bowel Grid can support you to address inequalities in bowel cancer screening. So hopefully helping you prioritise and target interventions based on their evidence-based potential to improve uptake in specific groups and then across multiple underserved groups, as I've said. Understanding which interventions map to which barriers as well, and using interventions that are actually designed to specifically address those things. And we've also got some guidance in the tool around implementation and evaluation of interventions. So if there is anything put in place, wherever we've got resources to support implementation, for instance, GP endorsed letters, we have a kind of template for that, or text reminders, telephone scripts, those things that we have templates for, and also evaluation, just helping you consider that being part of it, so you can measure impact of anything that's put in place. But yeah, as I've said, we strongly suggest that people use the tool in combination with local insights, data, and considerations, obviously, of capacity and initiatives already in place to tackle inequalities. And I think, oh no, I think there's one more slide. Next slide, please. And these are just some of the examples of some of the interventions that are included in the tool. So all the interventions have been defined in the tool. So there's a tab that defines what exactly they involved. Some of them obviously here are probably quite self-explanatory, and some of these might be suited to kind of more local GP practice or PCN level. Others more suited to national level. For instance, we've got annual re-invitation in there, which is something that might be coordinated nationally. And then next slide, please. Not moving on just yet.
Not quite what's happening here. Apologies. Kelechi, is it possible for you to take control? It seems to have frozen for me.
I believe the next slide just talks to the sort of impact of the tool, so I can talk to that. But yeah, we worked with some of our contacts in cancer alliances across England and some stakeholders in Scotland and Wales as well, to sort of design the tool to make sure that it was easy to navigate and interpret. And we launched it in mid-October, I think, last year, and it's been downloaded about between 450 and 500 times now. So a hugely popular tool that we hope people are sort of finding valuable in helping them navigate all of the research and evidence in this space, because we know it's a busy space. But yeah, something that can help guide decision making really around interventions. And I think that's everything, unless Hope you wanted to add anything.
No, sounds good, Emma. Thank you.
Thank you. Hopefully we can navigate forward to the next speaker.
Thank you, Kelechi. If you could just run that to my slides, please. Kelechi, is that coming? It's not coming through on my side.
Yeah, and it's not on my side either.
Let me try that again. Can people see my screen?
Yes, we can.
Okay, brilliant. So one of the things I wanted to do was just give an overview from an NHS England Equalities team perspective. So my name is Walter Johnson. I'm an Equalities lead in the vaccination screening team, and we look at a lot of insights and a lot of interventions. And going through the business planning round at this moment, we are assessing which projects and which interventions we want to participate in during the course of this year. And what I would say is the tool is a really important piece and resource to help us with that. And so one of the things we asked in the first two sessions was for feedback on the tool proper. And we got some from Dr. Power and Randev in the last session. And so I went and did had a go at feedback myself. And these are some of the reflections I had. Now, what's really good about the Bowel Grid is it does support systems to identify groups with lower screening uptake. And that's really important when we go into business planning. It looks at a lot of the barriers and enablers, and that's equally very important to really understand what are the drivers for uptake. It's very good at really pinpointing those specific population groups and using some of those evidence-based interventions. So there's a really good and comprehensive reference side of the tool, which is very, very helpful to understand what has worked and what hasn't worked. And one of my particular favorites is the no effect part, because that really allows you to understand what's out there that's maybe not been so useful, and of course what has been very useful. And of course it's designed to help reduce some of those inequality gaps in screening participation, which is a really vital part of what we do here in this team. And so going into system planning and going into business planning in Q4, really important that we really understand our population and really understand how the tool works, but also triangulating what we have in the grid and what we know, and some of those insights and bringing them all together in one place is really important. Another really one of our favorite parts of the tool is the evidence synthesis. So it really gives you a good breakdown as to how to understand a project and understand an intervention, and gives you a systematic way in how to look into it and how to analyze. And one of the things we often struggle with across systems is that evaluation piece, and the grid really gives you a great insight into how to do that properly and how to really give an evidence-based approach to understanding some of those interventions. So some of my key takeaways from the tool. So some of the screening inequalities we know are predictable and are measurable, and the grid really does help with that. Some of those targeted interventions for certain groups and targeted groups really can significantly improve uptake, and the grid really evidences that very well. Very important that we have partnership working and community engagement, because that's integral to what we do and integral to making changes. And of course, reducing inequality, it improves outcomes, it saves lives, and that's essentially what we're here to do. But what's really important is we give the feedback. So every 6 to 9 months, I believe the tool is being updated. We'll share the feedback survey link, but really important that, and I implore you to really look into the tool and also to feed back to the team so we can make those improvements and make an even more useful piece. In the last session, we looked at how some of the limitations around the tool are there around learning disabilities, and some of that has been fed back, but it's a great tool to take forward, and a great tool and something we should all be using. I'm going to pass over to Dr. Pam Hall, who's going to talk to us about bowel cancer screening inequalities from a regional commissioner's perspective. Pam.
Thanks very much, Walter. I've got a few slides. I've been asked to bring a few case studies from the east of England. Firstly, I'd like to acknowledge my colleagues, and let me make sure I can move the slides on. Well, the theme of the day has been IT problems, hasn't it? The slides are not moving for me, so I don't know if anyone else still has. Okay, great. Someone has taken control of me. Thank you. I'm going to request control again because it says my request wasn't accepted. So whoever has control, if they could please accept my request, that'd be great. So I'm presenting on behalf of the East of England, but actually the people who've done the work are my colleagues Julia Varnes, Olivia O'Shea, Samar Pankanti, and others, including Rebecca Roberts. And I still don't have control. So whoever had control before. Okay, great. So this is East of England, and these are our 8 screening centres. We work to the Eastern Hub and the Southern Hub, and our patch stretches from Norfolk down to Essex, and then you can see from Bedfordshire over to the sea. Next slide, please. Thank you. I've included this from fingertips just to give an indication of the variation by in coverage by geography in the east of England. And you'll see that the higher uptake areas include Norfolk and Suffolk, some of Hertfordshire, and we have 2 very low uptake patches, which are part of the South Essex programme. There's also lower uptake in this, which is I think that's Bucks MK and the West Herts programme. Not completely sure, but anyway, it's just as you won't be surprised to see the variation. It relates to things like ethnicity, deprivation, and you will no doubt have similar pictures in your regions as well. Can I have the next slide, please? Okay, so these are the 4 projects that I wanted to reflect on specifically, but also just to note, in italics at the bottom, you'll see that we're also supporting another 19 projects locally involving the bowel cancer screening programme, and that's through our Screening Innovation Fund, which we had some local underspend, which we're able to use in this way. So ICBs and PCNs could bid against it, and many of them are doing projects on things like targeting non-responders, specific materials for particular population groups, but mainly it's phoning non-responders, particularly people who are from non-white ethnic backgrounds, and also people with severe mental illness, learning disability, and other protected characteristics. Next slide, please. And the one after that, thank you. Thanks. So this project is current at the moment, and this text message reminder project has been a few years in the making. There were delays to actually being able to start it, and that was because there were just some difficulties in getting sign-off for use of the data in this way. The project is to offer a text message reminder to people aged 54 and 56 years, and that's because from the data that we were getting from our national colleagues, it was clear that uptake in the new cohorts, the younger age cohorts, was lower than in the more established cohorts. So how this works is it's quite straightforward. Participants get a text message 2 weeks after their kits. Can I go to the next slide, please? That just shows a little outline of how it works in practice. So there are 2 groups. 50% of the cohort will receive a reminder and 50% won't receive a reminder. And so far, the majority of people, it's been possible to send them a text message reminder. But it's worth noting that it's not possible for all of them. And I think others will potentially note this as well, that not everyone has a mobile phone and not everyone has their correct details on the spine. So that it's not possible to contact 100% of people by text message. So early data, it's looking like people who receive a text message reminder are slightly more likely to return their bowel cancer screening test kit. So that's quite exciting. Next slide, please. And the next one. Thank you. So this is another text message project which is actually finished, and this was also about increasing uptake, but instead of targeting age groups, this was targeted on specific populations. In this case, it was the Luton and Peterborough populations. Similarly, people received a reminder if they hadn't returned a kit. This time it was by week, I think it was week 8 they got, sorry, week 4 they got their first reminder, and by week 8 they got a second reminder if they still hadn't returned their kit. As I said, this project has finished. The change, there was a very limited impact, and I think what was interesting listening to the work about the grid earlier is the importance of learning what does work and what doesn't work. And we wondered whether this showed a low impact because the population, this wasn't an approach that was likely to make them change their behaviour. We're wondering whether the slightly younger population are just more used to being bombarded with text messages and it's more likely to change their behaviour. We just don't know. But anyway, in terms of the actual outcomes of the project, we've included a QR code which you can check out later. And there's lots of materials on there, including animations describing the pathway, targeted materials. So you may want to use those locally. Next slide, please. In fact, next 2 slides on, please. Thank you. And sorry, the next one as well. Great, thank you. So Beacon House is a charity in Colchester which supports people who are living with homelessness or insecure accommodation. And this project is to enable people under those circumstances to access the bowel cancer screening programme. So people can request their test kit to be sent to them at Beacon House. They can get advice on what the kit involves. If they test positive, then one of the SSPs from the North Essex Centre can potentially come and visit them. And if they need to if they don't have somewhere secure to complete their preparation, they can actually be admitted to hospital to do their prep and then have their colonoscopy. So this whole system's been set up. The numbers obviously are not huge because you wouldn't expect them to be. So far, no one has tested positive in the few years that this has been running, but we are reassured that if anyone does test positive, there is a pathway set up to enable them to access the full pathway. And then 2 slides on, thank you. And thank you. The final project I wanted to just pick up is the BEMA project with the British Islamic Medical Association. This one was also targeting Luton and Peterborough, but this was specifically about increasing understanding and awareness and uptake of the bowel cancer screening programme in Muslim populations. So this was a faith-based intervention where the intervention took place in local mosques where healthcare workers and community advocates went into the mosques and were talking to attendees about the programme using culturally sensitive materials. They were explaining the programme and how people could benefit from it. And it seems to have been a successful intervention in that uptake of screening 2 years after the intervention seemed to be higher in people who had been involved than people who were non-participants. So it was interesting in terms of making additional links in our community and giving some indications for what might be effective ways of targeting different population groups, specifically designing an intervention that meets the needs of the population rather than expecting the population to engage with something, a generic approach. And I think the next one's my final slide. It was just in terms of priorities for us, data, particularly ethnicity data, is a bit of a gap for us. So anything that anyone can do in terms of advising us on their successes about understanding their population needs by ethnic group would be really, really valued. But it was exciting to see the grid. I actually wasn't aware of the grid, so I'm hoping we'll be able to make use of that in our future work. Thank you very much. That's it for my slides.
Thank you, Pam. And there's a lot of discussion points there that we can take through to the panel discussion a little bit later. But I'm going to move us on to Dr. Mo Fufik, who's come forward to give us a really good presentation on ethnicity and colorectal cancer and understanding our population. I'm going to try and give you control, Dr. Mo, but if it fails, I'm here in the background.
Thanks, Walter. I hope you can hear me. First of all, thank you for the opportunity. And great to hear Pam's talk, because I was a junior doctor in Peterborough, and I've lived there for 5 years. It's a small story. It's a long story, but there's a lot of matching. So, but I'm not involved in any of Pam's work. It's brilliant. Hopefully, we will be involved in the future. So I'm a gastroenterologist based in Sheffield. I'm also the clinical lead for the South Yorkshire Endoscopy Network, and I'm a bowel cancer screener. I will see if I can make the slides move. Okay, so first of all, this work was supported by Yorkshire Cancer Research. The data, this was a national study, and it was quality assured by NHS England, and the data was available and accessed by Cancer Research UK. So the background to my study that we did, there was a sense of a feeling that perhaps there's a low uptake of screening among ethnic minorities. As Pam alluded to, we'd never had a sort of a ethnicity data nationally, and it was the first ever sort of a step that we did. And there was also a realization there's a poor understanding of colorectal cancer prevalence among different communities. We also felt that we should have a mechanism to identify the ethnicity of the colorectal cancer population. So, essentially, as you know, screening is done by utilizing the FIT test, which is provided to the population. And as you can see, somewhere around 2019, there was an increase in the sort of the uptake. This is because FIT test was introduced, and prior to that, it was an FOB, fecal alcohol blood, suggesting that perhaps there is an increase in the uptake. I think what we're trying to do in screening is, or in colonoscopy, is to try and find these early benign lesions, which are polyps, and before they become cancerous, so that we can get rid of these, so that the patients do not develop cancers. However, there are still about 10% of people who come in for colonoscopies in screening where we do find cancers. But what we're aiming for is to find these early precancerous lesions. So this is what we call as an adenoma carcinoma sequence, where the cancer, which is carcinoma, is originated from an adenoma, which is the polyp. So what we're trying to do is to block this adenoma carcinoma site sequence, so the polyp is removed and then the cancer is prevented. That is what we're trying to do. So colorectal cancer is the second leading cancer in the UK in terms of cancer deaths. As you know, screening was rolled out in 2010. FIT, as I already mentioned, was introduced in 2010. But we also know from sort of smaller studies that the uptake of screening in ethnic minorities is quite low. But there was no definite data. Why is screening important, and why is screening detected cancer important? As you can see from several multinational studies, we can see that the cancer detected via screening, they have a much higher overall 5-year survival rate, nearly 30%. And if you look at the colorectal cancer specific survival rate, and again, there's a huge difference if you detect colorectal cancer by screening compared to if someone is symptomatic. And even the disease-free interval, if you had screen-detected colorectal cancer, is much higher, nearly 10% more, suggesting that we should be detecting cancers by screening. What about UK studies? Yes, it's a similar picture. We know that screen-detected colorectal cancers do have a much better survival, survival advantage, whether it's to do with the severity, and also we detect them quite early, suggesting that early diagnosis of colorectal cancer is much more common in the screen-detected one. suggesting that we should be doing more screening and detecting more cancers by screening. Well, again, most of you are aware of the triage to colonoscopy is done via a FIT test. Population or patients in the symptomatic group are offered a FIT test, and if it is positive, they come in for a colonoscopy, and that's sort of the triage for most of the thing. So there's nearly 7 million population in England are invited to participate in for screening. Is about the uptake is about 67%, of which 1%, nearly less than 2% is positive. And I know Pam may have alluded to, but we're aware that the uptake depends on this is not our own study, but this is what the national data does show, that the uptake of screening nationally depends across England, does depend on the level of deprivation. The least the deprivation, the more the uptake is. So screening does not just detect cancers, as already mentioned. We detect polyps because these polyps are to be detected and removed so that we can protect any future cancers. And again, cancers are detected in about 10% of the time. And besides that, nearly 50% are significant pathology. So coming to our study, we did find, as I said, this is a national study. So we did find that nearly what we call is early onset colorectal cancer, which is cancer detected before the age of 50. You can see that there's a difference in the ethnic sort of spread. The non-white population tend to have a higher percentage of patients or people who are detected in less than 50 years old, suggesting that early onset colorectal cancer is much more common among the non-white population. Same if you look at the median age of diagnosis, you can see that there's a difference, much lower median age of non-white population, suggesting that there is a variation. Just to take the age, because often we assume that age is the most highest predictor of colorectal cancer, but we can also see that you can actually get colorectal cancer at an early age. Route to diagnosis, because we want to know how the patients are or people are coming to the diagnosis. We want them all coming via screening, ideally, or through the GP. We don't want them to come through emergency, because emergency means that they are presenting quite advanced and late. And you can see there's a difference in the route to diagnosis, suggesting that they're more likely, if you're belonging to a Black community, you're likely to be presenting to emergency more likely than if you're not. So again, stage of cancer is important from our point of view, because we want to diagnose cancers early. And this is not the screening, this is the overall group. As you can see, there is a huge variation in the stage of cancer, particularly if you belong to a Black population. You do tend to have a higher stage 4, suggesting that you're very, very advanced already at the time of diagnosis. So this particular next couple of slides are very specific to our South Yorkshire group, because this was where the original study was done. And you can see if you dissect the age of diagnosis, I mean, age of 60 is because that at the time of our study, that was the age of screening. You can see that nearly 41% of our patients were diagnosed before the age of 60 if they were of Asian population, compared to the white population of 17. And again, there was a difference if 5% more patients belong to the Asian group compared to the white population were diagnosed via an emergency. And there was also an increase in the likelihood of them having advanced or metastatic disease. Again, it's a little bit more grim if they belong to a Black ethnic group, suggesting that they're much more sort of advanced. Sorry, the color yellow doesn't seem to come up very well, but you can see there's much more advanced presentation if you belong to the Black population, and nearly 7% of more likelihood that you are diagnosed via the emergency compared to the white population. So just seeing that there's more to be done. So I mean, again, the same we use for a mixed group. I know I didn't have the slides for the mixed group in the interest of time, but again, there was similar pattern noticed if someone belongs to a mixed ethnicity. So I think in the next couple of slides, I'll just sum up. I know in the interest of time, we do feel that there's a low screening uptake. It could be because of poorer self-rated health. It could be poorer socioeconomic status, as we noticed before. There could be a cancer fatalism. Again, I mean, I've noticed people in our own areas sometimes do feel they do not want to store a stool in the house, or they may have younger population, as you already noticed. They may have working sort of life or caring for someone else. There could be a language issue, or could be a religious issue, as a PAM study shown. So I think I'll skip this slide just in the interest of time. There are some barriers to participation in screening. Could be social, cultural issues. Could be practical, as you know, I already mentioned it. Could be psychological, health related. I mean, I think COVID was a major issue, but I think some of the factors associated with COVID still seem to persist. So despite that, there are still several national and regional drives done here, both in our region and also nationally. And I've got some slides from our own team in South Yorkshire, and also some from Lancashire. And as you know, there's a drive to try and diagnose 75% of the common cancers, which would include colon cancer, which by stage 1 and 2 by 2028, and this is a huge drive to reduce health inequalities. I think I'll skip this slide as well. In conclusion, I'll just say, Walter, I'll just say early detection of colorectal cancer and precancerous lesions improve survival. There's a huge variation in the outcomes of colorectal cancer, as I've already mentioned to. And again, this was the first ever national study which looked at the inequalities in sort of looking at dissecting the ethnic groups. But certainly there needs to be more done to sort of improve the outcomes. I'll pause there and I'll stop control. Thank you.
Thank you. That was really insightful. There's a lot to unpick there, which we'll do in the panel discussion. And I know there's some work going on nationally as well to look at some of the drivers behind that. Dr. Pawan Randev, I'm going to pass over to you, and then we'll go into our panel discussion.
Thank you, Walter, and thank you, Mo. I'm going to talk about a project that we've developed in the East Midlands, and this is a project between myself and Laura Ashley, who's a professor of health psychology at Leeds Beckett. What I'm going to cover briefly, and I'm not going to go through all these slides, you'll get them all in the pack, is just a bit about intersectionality, and in particular focusing on type 2 diabetes. Type 2 diabetes is a condition which also shares an ethnicity deprivation gradient. And this actually starts to fit together with Mo's work, as you'll see in a few minutes. One of the key things to ask ourselves right at the beginning is that there has been a major shift. And if we'd asked this question, what is the leading cause of death nowadays in type 2 diabetes? 10 years ago, we'd have said stroke, cardiovascular disease. It is no longer so. And in the late 2010s, there was this paper which started to show this in a Scottish population, showing that actually cancer is the major contributing cause of death in type 2 diabetes. So we've got far better at controlling cardiovascular risk factors, and then further research highlighted this again, and Melanie Davis, who's a professor of diabetes in Leicester, published in the Lancet Endocrinology, talking about this is in 2023, talking about that this is now the right time to widen that general prevention approach, to reduce cancer incidence, and that cancer deserved a similar level of attention to the other previous cancers, the other previous complications of type 2 diabetes. The diabetes-related cancers are these top 6. There are others, but I'm just focusing on the highest volume. And of course, breast and bowel have screening programs. Insulin resistance is the underlying mechanism to developing type 2 diabetes. And there is, of course, a bun fight within academia as to how much obesity on its own plays a factor. But we've come to realize that insulin resistance as such will link into increased cancer risk. This does not affect patients with type 1 diabetes. But then we've had a series of papers coming out last year in the BMJ and other publications talking about insulin resistance, and in particular linking it back to a factor that Mo mentioned, early onset colorectal cancer. Now, Laura has done lots of work looking into whether people are aware of this risk. And her team surveyed over 300 people with type 2 diabetes. Just about 1% knew that there was an increased risk of cancer. So patients don't know. The next thing they looked at was this information available? The answer was no, not really. And then in addition to that, what we've now realized is that if you have type 2 diabetes, you're far less likely to take up bowel screening. And there's a factor of 12% in this study. But when you start to look abroad, this is something that applies to type 2 diabetes across the board. So this is Danish data published in 2024, where they have a single system and they're able to look at their data very easily, 10% gap. Are there any other approaches to it? This paper looked at, could we screen at the same level of risk? And if you have diabetes or metabolic syndrome, the precursor of diabetes, in fact, there's a good case to be made if we're going to screen at the same level of risk for starting screening 4 years earlier. This applies to breast cancer as well and cervical. The final paper in Laura's series looked at healthcare professionals. And what she found was that actually, when you look at practice nurses, who are the group that are doing and delivering diabetes checks, very few of them, 4%, and no one knew about bowel cancer as a risk. So the key thing with bowel screening is that, of course, it's a preventative program. We are hoping to pick up high-risk polyps, put people into programs where they're going to have surveillance and removal of polyps as they arise. And the latest data shows that quite clearly. The opportunity and the project is to use the annual diabetes review, use a MEC, or making every contact count, methodology. The patients, when they come to their annual diabetes review, they are usually seeing a trusted health professional who has continuity of care. And the additional thing that we offered was to ask a specific question about screening uptake as relevant to the patient. And if they hadn't completed their screen, to share advice. And given that we're all under time pressures, this advice could be given as an immediately shareable text with an informational video link and a SNOMED code allowing you to see that the advice had been given. An audit was undertaken in one of the Derbyshire practices, and if you look in the box on the right, the majority reason in this group of 82 patients with diabetes who hadn't completed the bowel kit was just that they forgot. Simple as that. And when they were reminded that there was an increased risk for them and this was the telephone number to ring, they said, oh yes, we'll ring. So the extended audit led to a series of conversations identifying in more detail why patients hadn't completed it. The big change that I've managed to implement is that ARDENS, which is the globally used diabetes template across England, has now got an additional element, which is highlighted in yellow here, which is advice about cancer. And now that this is available, we have a SNOMED code linked opportunity for healthcare assistants and practice nurses to ask that question, code it, and then to be able to go back and audit it within primary care records. Leicester adopts a slightly different template. We've adjusted that as well. The sample bowel screening videos we've got access to, and when you get these slides, you can click on any one of those and see what quality they are and whether they're relevant. So when we look at this, we're also very fortunate in Derbyshire to have the first Fit at 80 programme. And looking at the first 6 months of data, we've seen a third more people coming through because they're being screened at 80, with 38% more polyps. An interesting finding almost all the way down on this page, which is a 55% increase in patients with larger polyps. And from a biological perspective, those are the polyps that seem to develop in patients with diabetes because of increased growth factors. So where is the project at the moment? We have a pilot site where they have already, within this financial year, they've already used that advice giving in over half of their patients with diabetes. They have a population of 700 patients with diabetes. Speaking to the healthcare assistants and practice nurses, they really like that they have something additional that they can offer. And when they realise this is potentially a life-altering or a life-saving piece of advice they can give, they are engaged. They have also taken it to heart and extended it now to some of their other long-term conditions consultations. And the great news is that these consultations are already paid for in QOF. We're running into interesting discussions with our local medical committee about whether there should be a separate payment for this additional activity. I would also draw your attention to the planning pack for England, which came out in late January. And within the local early diagnostic plans, you will note that there is an example of how you can improve screening uptake by working with chronic disease condition checks within primary care. And I would propose that this is one of the options. That's the end of my slides, Walter. I'm conscious that I have whizzed through this at a rate of knots. If anyone wants to pick this up or have discussions about how you could apply it in your areas, please just drop me an email. My email address is going to be in the pack that comes out to you. Thank you.
And thank you. That was really insightful. And I know I've seen the presentation before, but actually looking at it again and seeing the simplicity with patients that are simply forgot as being the driver to transformational change, at least at a local level, is really insightful. So thank you very much for that. So now we move into our panel discussion, which is where we open the floor up to the audience to ask any questions of the panel members that they wish. Now, I know there's some questions in the chat and the Q&A, which I'll have to get to, but I know Jo Rwende initially had her hand up, so I just wanted to invite Jo to come in first, if you may so. Jo? Okay, maybe we've lost Jo. Helen. Kelechi, can you unmute some people that might want to come in? I think Helen's muted.
Okay, can you hear me now?
We can, thank you.
Brilliant. Okay, yeah, I just wondered with regards to the link between the type 2 diabetes as well, if there'd been any engagement with the National Diabetic Eye Screening Programme as to whether it could be raised at diabetic eye screening appointments as well.
Sorry, can I take that, Walter?
Yeah, please.
What I've done so far, Emma, is work with our regional diabetes teams and presented it to them, because we're still at the stage where the diabetes specialists aren't all aware of the link. But you're absolutely right. And certainly when I think about the work that was done in Scotland by Bob Steele, looking at linking the AAA programme with screening advice, there is a signal there. And for diabetic retinopathy screening, we have an uptake of over 80% broadly. And whether that is an opportunity, yes, I think it certainly is.
very much. Really interesting. Thanks.
Thank you. I'm just going through the Q&A. Joe. You need to be unmuted.
Okay, sorry, I figured
think-
it out. It's a really fascinating presentations, and I think that link between deprivation, ethnicity, and early diagnosis, I suppose early onset of colorectal cancer is really quite compelling. I was quite interested to see the information that you have presented around the link between type 2 diabetes and various cancers, particularly breast and bowel cancer. And the interventions that you've described, Pawan, just seem really practical and I'd say almost essential, considering the link and actually the importance of having a healthcare professional advocating for screening within this group. So in terms of actually rolling out the implementation of what seems to be such a common sense intervention, how best do we do this? Because we always talk about how we work in a very fragmented way. We don't facilitate learning of lessons. But I think this might be a really good example of something that we should try to facilitate being implemented across the country using these long-term condition checks to advocate for screening.
Walter, can I answer that, please?
Please go ahead.
Joe, thank you for those comments, and you're absolutely right. And the challenge at this stage is that we sort of fall between two big specialities, diabetes and cancer. And diabetes is unaware of it, so there's an educational aspect for them. I've also linked with the Royal College of Nursing, and I've been delivering webinars nationally for practice nurses, and so I'm working at that grassroots level. I'm also trying to influence GP trainers, and so this becomes a very compact project for their trainees who have to do projects in this way. The other key element here is that overlap between insulin resistance as a key driver for polyp formation. And in Nature, there was a paper 2 or 3 weeks ago showing that if you look at pre-diabetes in the UK Biobank data, even that has got a real sort of link. And there is much that we can do here in this space. At the moment, we have a particular issue around the GP contract, where the GP contract has been rejected by primary care, and as a result, any changes are being blocked. But the opportunity also arises with working with the professionals themselves who are delivering the care. And whenever I've presented, it's been seen as actually almost a professional duty to pass this information on as part of a diabetes check, because why wouldn't you? If you're checking somebody's feet and eyes and so on, of course you would want to relate to them the thing that may be the biggest cause of death within that condition. I'll stop there, Walter.
Oh, that's fine. Thank you. So I'm just going through some of the Q&A. There's a question here from Tanya on some of the nomenclature around breast screening, cervical screening, and bowel cancer screening. I don't know of any work that's been done in that area. Tanya, is the answer to your question. It might be something I need to take back to respective colleagues, but at least not at a national level, unless anyone could correct me here. I think some of the other questions in the Q&A have been responded to or covered. Forgive me if I'm wrong. And I can't see anything outstanding in the chat that hasn't been covered. But if anyone else would like to ask anything, please feel free. Rebecca. I think have enabled your mic, I think.
Yeah, sorry. Hello everyone. So I work with Pam actually in the east of England, and she mentioned that we were doing a kind of smallish project, supporting smallish projects to target screening inequalities. And when I looked at the Bowel grid, it's amazing, and I had no idea. So I'll have a good read through. But when I look at the references, it's all kind of published literature. And it strikes me that a lot of evidence that we're gathering in local areas, in small projects, probably will never be published. And I just wondered I think there is some grey literature in there, and we definitely will. I've taken note of the email address to forward any evaluation that we do. But just, I suppose, to promote that to other areas, that we're all gathering evidence perhaps in this area, and it would be really nice if that could be sort of included in some of this, and as much as possible. I suppose that's to Emma, really.
Yes, did you
Yeah,
want to come in, Emma?
agreed. No, we know that there's lots of sort of grey literature and local level evaluation. I guess we just had to sort of like draw a line of what was sustainable in terms of the evidence collation, and looked at published research because of the kind of evaluation frameworks that they have as well. But particularly for some of those evidence gaps, I think even grey literature could help us understand and fill those evidence gaps. I don't know if Hope is still here and wants to speak to that more, but yeah, particularly where we don't have any published literature, that grey literature can be really helpful. Oh, she's waiting in the lobby for some reason. But yeah, if you have it to share with us, we welcome you forwarding it on, for sure.
Thank you, Emma. I think we've got time for one more question from Divya, and I think I've disabled your mic, or enabled your mic even.
Thank you. You have. You should be able to hear me. Can I just check you
We
can?
We can.
Perfect. I was just going to ask Dr. Randev about your study. With the health, with the HCAs and the nurses who are now incorporating conversations around cancer screening, did you provide just information, or was there specific training? Because I know you mentioned making every contact count, so did you use that, or was there any training packages used in particular?
I've developed a training package, and if you look towards the end of my presentation, there's a slide with an image of myself and Laura on it. And if you click on that, it takes you through to the 10-minute training slot. The training to deliver this actually takes about half an hour if you do it in person. And the reason is that the attendees just become so interested in the topic that you end up having lots and lots of questions, and it ends up being a very interactive session, which works much better in my experience, because then people are engaged. They try it out at their next diabetes clinic, find that actually it's no big deal. It is all supported, by the way, with CR UK literature, which you can order for free from their website, so that for those nursing teams that want it, you can hand something over to the patient immediately.
Thank you. That's really helpful.
So unfortunately, we're at time now, but that was a really engaging session and a really insightful session. So I'd like to thank Emma, Pam, Mo, and Pawan. Their details are in the chat. If not, when I send the slides and the recording, please do connect and get in touch. Really enjoyed the session. There'll be another one next month, and details will follow. But thank you for joining, and enjoy the rest of your day.
Thanks, Walter. Thank you all.
Thank
Cheers.
you.
Thank you. Bye now.
Hi, Mo.